Melinda. And I'll hand it on to you. Thank you.
All right. Well, thank you guys for having me. It's wonderful to be here. My name is Melinda Kent. I am with CMQCC. I'm here today to talk about our maternal data center. And like I said, it's a pleasure to be here today. I'll share a little bit about myself to start. My background started as a labor doula a long time ago. And then I became a labor and delivery nurse. I have worked in clinical IT, working with teaching fetal monitoring, not only how to read the fetal monitoring, but also installing fetal monitoring and working with nurses and doctors in the technical aspect of that. And doing some go lives in that, went back to bedside nursing and went into quality management, and that was how I ended up here. So putting my clinical and my quality and my technical skills all together. And so I am here today to share that with you guys. So I'm going to go ahead and share my screen, and we are going to go through a lot of different things today. And I ask that you save your questions for the end if possible. And I am going to move a little bit rapidly because I know that we have a lot to get through today. Michelle did send me a list of items, and so I am going to try to get through most of those. And some of them I know I'm going to be saving for questions because they're more of things that we will talk about. I also will send Michelle a bunch of links that you guys can click on to get some of the information, because we have user guides on a lot of the information too, and those will be good for you guys to look at. So let's go ahead and get started. I'm going to go ahead and share my screen. Let me know when you guys can see it. Can you guys see it okay?
Yes.
All right, perfect. Then we're going to go ahead and get started. So like I said, I'm with the CMQCC Maternal Data Center. We are currently building a New Mexico Maternal Data Center, which is extremely exciting. Everything that you see today is going to be included in that. It's not like a piecemeal, this is how you start and then you have to pay extra to get this or that. That's not how we do things. Everything is included. And the reason that this is built is for quality improvement. It was built for that intent. It was built for hospitals. It was built for exactly that reason. So I want to make sure that you guys know that that is what the heart of it is, and that is why we're here. So I do want to start with that there are no commercial or financial disclosures or conflicts of interest that I need to share. We're all here for the same reason and purpose. And I also have no hospital-specific data being shared today. Any hospital data or looks like hospital data is all data presented that is demo data. So it's not real hospital data. So I just want to make sure we know that as well. I'm going to share here my team. We have a tiny but mighty team, and I have a program manager lead, a program manager, and a data analyst. We also have our two tech supreme data team who also have a team behind them, but this is the two primary team that we work with, and they know our data center inside and out. So it's wonderful to have them behind us. Let's start talking about what the data center is, who CMQCC is, a little bit about our background so that you understand that this is not some huge software company that has 9 different types of software that they work for and with. This is really the only thing that we do. So CMQCC is a California Maternal Quality Care Collaborative. Our mission is to end preventable morbidity, mortality, and racial disparities in maternity care. We are based at Stanford University School of Medicine. So we understand the university lifestyle and environment, just like you guys. We are a multi-stakeholder collaborative with focus on hospital members. So we completely understand exactly that environment. We provide programs and tools to support hospital quality improvement activities. We're committed to evidence-based and data-driven QI. So anytime we add something in the data center, everything that's built in the data center is there because we believe that there is utility and use for it. As time goes by, if we see it's not being used, if we see that there really isn't use for it being there, then we will retire it over time. Sometimes we have good reasons for putting something in the data center. There were a lot of requests for it, and then over time it just becomes either antiquated or there really wasn't much utility for it, and so we will clean things out. The online course developed by CMQCC in 2012 And the primary goal was to inform and support hospital quality improvement, provide rapid cycle metrics to the hospitals, use data to drive QIs, leverage the existing data sources to minimize hospital reporting burden. We know, I have been in the shoes of the people. I was one of the people at the hospital that was gathering the data, reviewing the data, doing the chart reviews, and I understand exactly what that's like. So we do not want to add extra work if it's not needed. There does need to be a human being involved reviewing the data, so we do need to take that into consideration. We align the QI measures with measures used for performance reporting. So our goal is not to increase any extra work. Sometimes there is extra work that needs to be done, but we really do take that into consideration. We provide an intuitive and easy to navigate interface. Anything that you look at for the first time can be confusing, but it really is just click and click and click. There's really not much more to it other than that, so it is very, very easy to use. We provide exceptional customer service. This is something that made me want to come work for CMQCC and work for the data center in particular. I started as a clinical lead with the organization. And when I was asked to step into this role, I really had to do some thinking. Is this pulling me more away from the clinical, which is my passion and love? But something that I do love that really drew me to this was the highly responsive help desk and the support that we give to the end users. I've been on the side of needing to open a ticket. And if you're in the middle of the 2 hours that you have away from the bedside or away from your patients or away from working with your team to do this work and something happens that stops your work, you need that answered right now. And so I really impart that upon my team, and they really take that seriously. If I see a ticket not being answered that I think in my clinical mind needs to be answered more quickly, I will tell my team. Sometimes they're unhappy with me, but that's okay. They may not always make the wise decision that I think needs to be made. They may not triage the tickets accordingly because in their mind, they've never worked clinical. They may not know that this one really needs to be answered before that one. So I really take that seriously. We have continual enhancement of the MDC. We are constantly improving. And this is based on hospital recommendations, coding updates, national standards. As things evolve and change, so does the MDC. Joint Commission, we are at the table with them every quarter. We just had a meeting this week. They have a new e-measure coming out. They wanted to run some stuff by us and our clinical lead team before they made some final decisions and finalized that measure. So they wanted to make sure that what they're seeing when they tested it aligns with what we know clinically and with what our clinical lead team works on in our clinical quality collaboratives and all of the guidance that they provide to the hospital. So it's great to be at that table and know that we're having impact at that level with Joint Commission. This is what our landscape looks like. We started in California, like I said, in 2012, and two of our hospital systems also are in other states, and they wanted all their hospitals to be in the MDC, not just in California. And so they asked if we could expand into other states. So very quickly, you can see in 2014, we expanded up into Oregon, and then in 2015 into Washington. And we also have hospitals in Texas, New Mexico, and in Hawaii, not very many, but a few because of those hospital systems. So expanding into other states became very quickly identified as something that we were going to need to continue to support. So we built the national portal. And then we expanded into the national portal with a few additional hospitals, and then we started getting calls from other states. So we are currently working with New Mexico, Greater New York Hospital Association, and Minnesota with bringing in an additional 21 hospitals this year right now that we have in the middle of contracting. So it is growing in the national portal, and I anticipate it's going to continue to do so. Very exciting. So when we ask hospitals and we put out surveys and Qualtrics and we ask them to send this in, the ways that they are using the data center, these are the top reasons that repeatedly gets reported. So informing organizational strategy and direction regarding perinatal care initiatives, tracking facility performance, motivating QI work at the facility level. Love that one. Facilitating reporting to data agencies. So a lot of hospitals will use the data center to help gather the data that they need to do their reporting. Participating in payer incentive programs. Now, this is something that we do strongly in California. Oregon and Washington are not using it as much for this. I could really see New Mexico going this route one day. So this is something that I really would love to work in New Mexico on. So in California, we have a lot, probably a good 12 or 14 different payer incentive programs that Health Net, Blue Cross, I could go on, but work with us, and they work with their hospitals to have a release form in the data center, and they'll say to the hospitals, like, if you bring your NTSBU rate down by 2% over the next 2 years, then we will do this payer incentive program with you. So they work with their hospitals. They put together the programs. We have nothing to do with it. They just come to us and say, this is the program we put together, and this is the list of hospitals. Can you do the release form in there? They already know about the program, and then we work with the hospital. So it's been a great thing, and we've really seen a lot of quality improvement around that. It's been wonderful. So to inform staff training and educational opportunities, identify data quality improvement and coding opportunities. That's a huge, huge one. And now we will get a lot of help desk tickets that come in where they will write to us and say, hey, I'm not sure why this patient is in my NTSB population. You know, it was their fourth baby. Not sure why they're in here, because they shouldn't have been. And we'll go back and look, and we're like, they were coded as it being their first baby. So then they got to go back to their coding team and say, hey, this is our fourth baby. It says right here on their H&P, and I'm not sure why it was coded this way. So they'll start noticing these coding opportunities, and it's really bridged the gaps between the clinical team, the leadership team, and the coding teams, and they work together really well now. Getting quick answers to perinatal practices, that's another thing. And my team has gotten really, really good, and they have a whole library now of ACOG, AWAN, AIM resources, and they send out the links. We don't answer our opinion. We don't answer CMQCC's perspective. We only give out evidence-based sources. So it's been a really wonderful partnership in that way. And then a survey of CMQCC member hospitals, why use this system or tool over other systems or tools? So for benchmarking and comparative statistics, so let's just say one day we have all of New Mexico birthing hospitals in the MDC. Hospitals can then look at, how do I compare to all of the other hospitals? They cannot see other individual hospital statistics by name, but they can see that my blah, blah, blah rate, my episiotomy rate is X, and compared to the rest of the state, which is Y, which is really, really powerful, especially when you have somebody who thinks that their rate is great or horrible, and then they compare it to the state. So that's a really helpful tool. Easy trending and graphic downloads, and that is so true in here. Ease of access, it is very easy. Patient drill down features, so there are quite a few tools out there that can gather statistics, but I don't know of one that does the patient drill down the way we do, and I will show you that in here. And it's really helpful because you can go down all the way down to the patient level, and then you can do a review in your EMR of that patient, because it will point you down to a specific patient. Or if you have a specific number of fallouts, you can go into each of those patients, and now you know which patients they are, so you can go back in your EMR and do a more detailed review. ICD-10 code listings enable easy ascertainment of coding opportunities. And you can see, I'll show you in here, when you hover over the ICD-10, it tells you what that ICD-10 means, which is fabulous because most of us don't have ICD-10 codes memorized. And then a single uniform database of various staff can access and utilize. And I will also show you today how we have various levels of access. So you can have your administrator that can do everything in here, including making changes, all the way down to somebody that can only view, cannot make any changes, and only can see aggregate. So they can only look and see that, okay, my unit blah, blah, blah rate is this for the month, or this for the quarter, this for the year, and that's all they can see, and they cannot see anything else. This is what our landing page looks like when you log in. Like I said, this is a demo hospital, so Schinner Hospital is not a real hospital. And your favorite measures can be on there. So if you happen to be a bedside nurse and you have access, but you are working on a quality project, you can add your favorite here. So if I'm working on a project for sepsis, I can add my choreo, and I can add my episiotomy rate, and I can add my SMM. And that's what I'm going to see when I log in. I can see all the other measures if I go in and click down to look at them, but that's what I'm going to see every time I log in, which is really nice. And then I can go into these other areas and click around to see where I'm at. The top right corner shows the rate or the number of inborns for the year, and then the year to date, and it also shows for the month. And then we have our QI initiatives, which I will explain a little bit later. Okay, and now we're going to go into our MDC roles. So just like any clinical tool, whether it be your fetal monitoring, it be your EMR, it be anything like that, there needs to be different levels of access. You don't want everybody to have the same level of access, right? So for the person that's in charge of providing access to the tool, you want people to be able to go in and do different things, right? So these are the roles that we have available in the MDC. I'm not going to go through them in major detail, but I want to just impress upon everybody that there are different roles, all the way from the read-only aggregate data only, all the way to the left, like I said, and all the way to the right, we have the administrator. So we do have all of these different roles that can be provided and allocated to different various users that you would have in the MDC. So it's very useful, and this allows for you to have even your bedside nurses be able to go in if that's the route you want to go. We have some hospitals where every bedside nurse has access to the data center so that they can all be, informed, and there's a lot of transparency. And we have some that they're not that way at all, and that's just not the climate that they have. That's not. So it's really up to the hospitals how they want to handle that. We have some where there's 4 or 5 administrators in the hospital, and the administrators work on different things. And then we have some hospital systems where 0 administrators at the hospital level, and only the system has administrator level. So you can see that it's all a different range of how it's handled. We at QCC do not do any user access, none. We give the very first administrator access, and that's it. From there, the rest is all up to the hospitals, and that's for HIPAA, it's for security, and it's also so that the hospitals are in control of their own data. So we are very hands-off when it comes to that. We do not have access to any of the patient level data when it comes to identification of patients and the such. So it is really important that everybody understands that. Our goal is not to get access to the data. Our goal is to provide you guys the tool, the MDC tool for you guys and the hospitals to do the work and have access to the tool. I'm going to touch base real quick right now and share how CNQCC has aligned the maternal data center with Joint Commission's long-standing maternal safety standards, and how we align the data center with our CNQCC toolkit, and how anybody who has access to the MDC gets the benefit of that alignment. It's really exciting. So I'm going to give you a couple examples. We're going to start with the hemorrhage toolkit. So the hemorrhage toolkit that CNQCC has written really helped across the nation, and even in other countries. We've had other countries using this toolkit to really help with make sure that there's hemorrhage carts on every unit across the nation, etc. Make sure that we're doing stage-based evaluation of hemorrhage. And what the MDC does that is so beautiful is that we have, for so many different areas of maternal care, we have chart review options, and we call them options because there is nothing in MDC, and there's nothing coming, no message coming from CNQCC that every hospital has to do every single chart review on every single patient. That would be impossible. But we do have a lot of chart review options in the MDC. So what we like to message is that is up to the hospital to determine where they want to focus. Every hospital is going to be at a different place. Every hospital has different resources, and we completely understand that, right? So it is going to be up to the hospital to decide what to focus on. So let's just say in the best case world that everybody was focusing on hemorrhage and everybody wanted to do 100% charts, which we all know is not possible all the time, but let's just say that's the world we're living in. Then I would say go in and then, focus on all of these chart review options, and do 100% of all of the cases that show up on the screen. The way that the cases show up on the screen is beautiful in the MDC, is that it selects the patients from the populations that meet the criteria based on what is coded and what is uploaded in the MDC. So for example, for hemorrhage risk assessment, it is going to want to know all of your patients that were admitted to your unit had a hemorrhage risk assessment completed, and it's going to want that audited. That's kind of a given, right? Like anybody that comes in should have that done. For a QBL at delivery, some hospitals, let's be honest, have not even started doing that. Most hospitals are doing some form of QBL. All hospitals that I know of are doing some QBL, EBL, something, right? And I think all hospitals know that they want to be doing QBL. So it's up to the hospital to decide what they want to do with this. If they're not ready to do that audit, they're not ready to do that audit. For the hospitals that want to do that, it is in here. And it is there, and it's available, and it can help guide them through that QI process and the ability to audit for that. Now, what's their goal? That is up to them. We don't put in there that 100% is what you need to meet. We don't put in there that 80% or 50%. It is up to the hospital to set what their goal is. And that is also part of the QI initiative area in the MDC that they can use. So they can set up a QI initiative around that, and they all work together. The transfusions, all RBC. This is something else. Not everybody goes in and works on making sure that their transfusions were appropriate, that they were timely, that they were documented well. But if you wanted to work on that, this is in here, and it ties in with hemorrhage. So you can see how we have these chart review options, and they will guide you through auditing what should be audited. But if you don't want to use that, you don't have to. But these are all the options that have to do with the hemorrhage and the hemorrhage toolkit. And then it has the purpose of the chart reviews. So validating QBL accuracy, assessing the stage-based response, confirming transfusion appropriateness, and identifying SMM hemorrhage cases. And then the key MDC metrics that go along with these. So SMM hemorrhage, transfusions, and QBL performed. So these all support what's in that toolkit. And then we have also hypertension and preeclampsia. So we have the toolkit and chart review options, the purpose of chart reviews, and the key MDC metrics. So I don't want to take up too much time on this, but you could see how we could go down the rabbit hole with all of the toolkits, all of the ways, and this is all built into the MDC. And I will show you what that chart review screen looks like. And it's built out for a lot of different areas. So I will share this slide deck so you guys can go back and look at this if you're interested. So what MDC features do we have to support hospital QI? So I did just show you that, and we will see what that looks like as a visual, but we have over 230 clinical quality measures, and it's growing. And then we have different categories. So when you go in the MDC, and we'll show you that you can look areas, you can look up items based on the category, which is on the right here. So cesarean delivery metrics, vaginal delivery metrics, overall delivery metrics, maternal morbidity metrics, all of these different categories. You can also look them up by name. So on the left, you can see they're in alphabetical order. You can also look them up by organization. So we have baby-friendly metrics. We have, I'm trying to think, like all of the different organizations, Joint Commission metrics, leapfrog, or leapfrog metrics. We have all of the different organizations, we have metrics. So you can go in and look them up that way as well. In MDC, we have run charts. We have hospital performance over time that shows, and when you look, you can see them by monthly, quarterly, annual basis. And you can also click on any of the outcomes, and you can see the reporting period drilled down. So here we're looking at it on the left, you can see it says Q1 2022. If you click right here, it's going to take you into this. I'm going to go back and show you. It's a 17.7% for the quarter. When I click on it, it's going to take me into the quarter, and I can see all the cases that were in there for the quarter. And that's what I mean by getting into the patient level. So right now I'm looking at every single patient that was in there for the quarter. And it's showing me that for that quarter, we had 11 fallout cases. So now I can see that in that quarter, these are my 11 cases that fell out. We would be happy to have only 11 fallouts in a quarter, right? Anyway, so these are the 11 that fell out. And I can see the MR number, the delivery date, the discharge date, the diagnosis, birth weight. I can see all these pieces of information, which is fabulous. Something that's really helpful in here when you're doing your reviews is this little comment box. I used to use this all the time. I would put in here anything that I found that I wanted to remember in the future, And when I hit download Excel, all of this can download into Excel so that I can have a record of what I audited. And then this little comment box also downloads. And then I would have one Excel sheet that was January, February, March, April, May, or you could do quarter 1, quarter 2, quarter 3. And I'd have one Excel sheet for the year of my audits for that year. And I could go back and look for trends. So it's really just a fabulous way to be able to do audits. And this is just showing you for NTSV, but you can do this for your timely treatment of hypertension. You can do this for your hemorrhage. You can do this for any of the areas that you're reviewing. So the drill down screen also lists the ICD-10 codes. And like I said, that the user can hover over, can hover over the codes and see the detailed description. You can see that right here. The functionality enhances data transparency and allows for a more comprehensive review. When you're reviewing this right here, and you can see the ICD-10 codes, and you can review all this data, and then you can put a comment in this box that other reviewers can also see. Now you're all communicating with each other. So you can put it in. Now night shift comes in, they're doing reviews, and they can see it. It's great. This comment box shows up in other areas. So let's say I go in and I see that there was a comment that somebody else put in from a hypertension review. It may also help me with this, because now somebody's doing hypertension reviews, I'm doing MTSV reviews. If it's two different people, that comment might help me with this audit too. So that comment box is a very useful help. You can see peer comparisons. So in this area, the benchmark is against other peer comparison groups by NICU level and by delivery volume. So right in here, it is showing all MDC, and that is something that New Mexico will get, and it will show all MDC for Oregon, Washington, and California. So if you're thinking 20.1, oh my gosh, that's not that great. But then you start seeing that, oh, okay, but for our NICU level, by the way, 20.1 is great, but I was just throwing that out there. But against all the other NICU levels that are the same, and the hospitals that have the same delivery volume, wow, we're actually 20.1 is good, but it's actually really, really good. Everybody else in this same kind of, area as us, we're actually doing even better than I thought we were doing. So it's really nice to be able to see that benchmarking. Another area that you can benchmark is in these caterpillar graphs. These are my favorites. So you can see that your hospital's right here. So Mueller Hospital against all the other hospitals is all the way to the left, which for NTSV is good. You want to be lower. This was really, really helpful. We were I was leading a timely treatment of hypertension improvement project, and we were moving the needle, but slowly. And when I went in and I compared where we were across the state, it was so helpful because we were not hitting 80%. We were not. And we really wanted to hit 80%. And the CMO and CNO were getting a little frustrated, and they knew the nurses were working hard, and they were like, how can I cheer them up? I know they're working hard. And when I printed this, it showed how far we had moved actually up the graph, closer. We were doing better. And when I showed them that, they were so excited. And so to have the CNO and CMO go to the unit with this graph and like do this cheer up talk for them was just really, really exciting. So this graph made a big impact on everybody's morale. And sometimes just a picture can speak 1,000 words. So really, really helpful. And so you can also toggle your comparison group by clicking on this. And sometimes there's 3 or 4 different dot options, and you can, select which one you want to look at. So for here, it was toggling between state and nursery level region. Balancing measures are very, very helpful. Here we're looking at, here we have our NTSV rate, and then we have our unexpected newborn complications. And we can see that as our NTSV rate was dropping, our unexpected newborn complication rate was also dropping. And then we had an anomalous month, whereas our NTSV rate went up. As our NTSV rate went up, our unexpected newborn complication rate went down. And so we were like, that's a little bit weird. But then overall, it actually followed the pattern that we were hoping it would follow. So we just need to keep watching this to make sure that we're not having any untoward effects, right? We don't want to pause problems with the interventions that we're doing. So it's really important to find a balancing measure and make sure that we're having the right impact. And so this really is important to watch, and it's really great because in MDC, you can compare two measures with pretty much any of the measures that you have. So if you're concerned that you're seeing a negative, you can put these two measures on the same graph, and you can look at them, you can print them, you can talk about them. So this is great to be able to throw those on and just pick the two and look at them. Measure analysis is another unique thing we have. We've added this for a lot of our measures. It's not on there for all, but you can always put in a request for this to be added if it's not on there for something that you want. So measure analysis, you'll see off to the left in the MDC for measures that it's available for. And the measure analysis allows hospitals to implement targeted quality improvement initiatives aimed at improving the outcome, rather than just wondering, like, do we need to do this QI project for the whole unit in all ways, in all areas, and expend your effort everywhere. So the main trend screen helps us understand the overall trend, but not necessarily what is driving the trend. So the measure analysis is the tool that allows hospitals to break down the overall rate in a more granular sub rate. So it helps you understand the nuances. So when we look here, we can see that we have our Brightenberg Medical Center, and then we have our NICU level for all of the MDCs, so our NICU 3 and 4 levels. And this helps us identify the drivers of cesarean delivery rates. So we have it broken down by spontaneous labor, induced labor, and no labor. And most of the time, we agree that induced labor is generally the most thought about driver for cesarean section. But Brightenberg seems to have tackled that pretty well. And as they've brought down their induced labor cesarean sections, their spontaneous labor cesarean sections have been suffering. And that is now their area that they need to focus on, which is counterintuitive. And this really shows them that this is where they need to focus. If they continue to focus in this area, they're not going to have as big an impact. So we would recommend that they go in here and do a bit of a deep dive on this 11.5%. This graph doesn't show which time period they're looking at, but in this time period, and see if there's some opportunities they can identify. Maybe these patients stayed in bed and didn't move a lot, and maybe they need to get their spontaneous labor patients up and moving. Whatever it might be, but to focus on evaluation of those patients and try to figure out what the common denominator is that they need to focus on, and see if they can put some interventions in that place. And so it shows that beautifully here how identifying what the drivers are can really help you focus where you need to identify your opportunities for evaluation of the data. So the provider level metrics in here are great. It really gives you opportunities to parse the data the way you'd like. You can look at all these different areas you can divide out. You can look at the areas of time frame that you want to look at, and you can also look at the minimum denominator size and change whether you want the denominator. Like if somebody did 3 deliveries, it's going to show that they're a much higher percentage, especially if you're looking at like an NTSB rate, right? So if they only did 2 deliveries in the whole year, do you really want to look at it 100% if 2 out of their 2 deliveries were NTSB, or do you want to make it that they have to do at least 20 deliveries? So that's something that the person evaluating the data can decide. And I love that that gives you the opportunity to do that so that you can really decide how you want to focus. And so this area really is great when you're evaluating the provider level metrics. And you can see over here that you can also decide if you want all your providers, you want to just bring it down to family practice, you want to bring it down to your nurse midwife, you want to do OBGYNs, you can bring it down to practice groups if you have built practice groups in there. So it can be very specific depending on how specific your administration of the MDC, your administrators have built out the MDC. All right, moving along. We do have a lot of birth equity resources in the MDC, and this is going to be dependent on how well your hospitals submit race and ethnicity data. We have some hospitals that this does not work as well for them because they don't gather this data as well. So it really is going to be dependent upon that. But for the hospitals that do, and most do, this is really a wealth of information and data for them. And let me see really quick if I have a screenshot. Maybe I don't. Off to the left in the MDC, when we go there, I'll show you. There is on most of the screens off to the left, you can click on race and ethnicity, and you can bring this data down, and you can look at it in this way for almost all of the measures. So it's really wonderful. So for SMM, we have condensed down the CDC's 21 SMM complication indicators, and SMM's MDC table shows the 8 categories, as you see here, and we bring them into the SMM, the morbidity, or sorry, maternal morbidity, and separates them out into race. So hovering over category then will list the included SMM complications. So you can see here that we're hovering over hemorrhage, and then it shows you that DIC is in there, and then shock is in there, and hysterectomy is in there. So it bundles your cases together because there's such a minimal amount of cases that separating them out is just way too long, and they don't all fit. And so doing this brings them into one page, and then you can go focus in. And if you click on one of these, it does take you into another page that then has the cases all separated out. So SMM is in here as well. And we have the Joint Commission Standards of Maternal Safety built in here, which will be adjusted a little bit coming soon because Joint Commission has changed this recently. So those of you who aren't aware of the changes, keep an eye out for those. Joint Commission has announced it in some ways, but they will be announcing it a little more widely. And that was as of January 1st. So they've been announcing it since June of last year. And it's going to be more based on their audits that they do in the hospital, and all of these are rolled up into the audits now. So, but we have these built in here. You will notice they will be staying exactly the same. They won't have the Joint Commission name on them, but all of these are built in here, and it has implementation of resources. Clicking on these will take you into the different resources that are available, the toolkits, the recommendations, sample, policies and procedures. It's a wealth of information, this area. I'm going to scroll through these. Here we are, the quality improvement initiatives. This area is a wealth of information as well. You can go in here and select from the key drivers of maternal morbidity and mortality, other drivers, and then other QI initiatives, and you can add your own. So if there's something that you're working on, you can add it. We have all of the AIM bundles built in here. So if you are working on an AIM bundle, then this is going to be an area for you. They are all marked with a little purple A, which will be helpful. And the AIM measures also will be populated in here as you submit data. So you can see the little purple A, and you click document activity, and it will take you in for you to document the different activities that you're doing. You can go in and enter your own target. We know different hospitals have different targets. And then your target will be updated in that target column. And if your target changes over time, sometimes people reach their target and then they want to raise the bar. And so they can go in and edit that target, and you can just go in and edit it. We have a section in the MDC called What's New. It lives at the top of the page up here. This blue bar never changes. It always says admin, support, what's new, and search. So if you're ever wondering what's new, you haven't been in MDC for a few weeks, you want to know what's new, or you've been on leave for 2 months, you come back, what's new? You click on what's new, and this will open on the left side. You can click on any of these what's new announcements, and it will scroll automatically to that announcement, and it will tell you what's new. Pretty easy. So as things roll out in the MDC that are fairly large, we will put a what's new announcement. So like here, the US News and World Report survey was updated, and so we put a what's new. So we will update those so that we can keep everybody apprised, and we also will send out a push report to all of our hospitals, so they will get a little memo that tells them things that are going on as well. That's how we keep everybody updated. In the MDC, we have optional measures. So your hospital, it'll be your IT department or your quality management department, and not many, but some hospitals also, it might be their MDC administrator will upload a file once a month to the MDC with your patient discharge data, and that will populate about 75% of your measures. automatically. You don't have to do anything. And then there's optional measures that over time have grown to about 25% of the measures. And those are measures that extra data has to be entered. So it's up to your hospital, not mandated by us, okay? So if you want those to populate, for example, I'll give you an example, hemoglobin on admission. If you want to track hemoglobin on admission and the measures that come from that data, that's a supplemental measure. There's two ways that data can get in. One is by hand keying it in. Not fun, but you can. I wouldn't recommend it because I don't know that it's going to be totally accurate all the time, but that's a bummer to have to do that. The other way is by a supplemental file. The supplemental data is a file that whoever uploads your patient discharge data also can upload a supplemental file. They can do it with the discharge data, so it can be part of that file, or they can do it as a separate file. Sometimes it's a separate person. So some hospitals, whoever does this patient discharge data, that same person will upload the supplemental file. Sometimes, especially in Epic, there's a way to build like your own report. Some people know how to do that on the unit. And so like I built my own report to be able to help me with some of my audits. I built a report, and then there was people that in some of the hospitals were able to make it so that they could then upload a report. So there's some hospitals where people do that, and it's then their quality person that does that. So you can calculate optional measures that way if you want to. So we can help people learn how to do that if they want to upload a report. So there's, like I said, manually enter via specialized worksheets, or they can submit supplemental data files on the internal system. This is what the chart audits look like. So you go in and MDC will tell you which charts need to be audited. There's a way to tell it to sample, and there's a way to tell it to pull all the charts. Okay, so you guys, that's up to you. And then it will ask you the question, was this patient admitted to the NICU? This is for exclusive human milk feeding. For anybody that's done that audit before, it only includes patients that are 37 weeks or greater. So rather than you having to go through every single patient and looking and seeing if they meet that criteria, the MDC does it for you. It tells you this one is less than 37 weeks, they're excluded. Okay, great. And then you say, if you put a yes for a NICU, if yes, the baby went to the NICU, it's not gonna include it. If in the coding it says the baby went to the NICU, it won't include it. But here it's included, so then you say, yes, the baby's in the NICU, it won't include it. And then the one thing that is not included in coding here is whether the newborn was exclusively human milk fed or not. You need to put that information. So you put yes or no, and then it gathers all that info, and then it populates PCO5. So that's another one that is an optional data. It doesn't automatically come in, but you can add that. You can also have a report built by your IT team, and they can provide the supplemental data so that your PCO5 information is populated in the MDC. So we leverage, like I said, the submitted PDD data and then the clinical data that you already have in your EMR. You can also leverage that to put that in here. Some hospitals have, and I have them build this at the hospital I was at, a discharge question that the postpartum nurse has to answer. Was the newborn exclusively human milk fed, yes or no? And they had to answer that upon discharge. It wouldn't let them discharge the baby until that was answered. And that's where they populated the information from. And then that was included in the document that got uploaded. So it automatically filled it in. So there's different ways that this can be done. And then, yes, the data can be edited if it needs, and then it calculates the measure. So then we have the measure calculated. So there we go. So there's a lot of data quality that's in here. As you can see, we have all of this data quality. We want to make sure that the data is good, right? So we have data quality measures for our data quality measures. So we can see here, birth certificate records missing a newborn discharge match. So we get in California, this is actually a California one. I probably shouldn't have this on here. In California, we get the birth certificate from the state. So we have this set up that we're saying we have a baby, but we didn't get the birth certificate. So let's throw that one out. So here's one. Let's see, inconsistent live birth information. So we're saying that, you know, what's on the mom's record about the baby is not matching what came in from the hospital about the baby. That would make sense, right? Or maternal, let's see, missing inconsistent delivery methods. Maybe on the baby's coding, it says that the baby was born vaginally, but on the mom's coding, it says it was a C-section. That's not going to be a good thing. So these are the type of things that are in here. Missing or inconsistent gestational age among less than 37-week newborns. So on the mom's record, it says, let's say one thing, and then on the newborn's record, it says a different thing. When the two aren't matching, that's what will show up on here. Here's one in red, 18.1%, 92.9%, missing or inconsistent Medicaid status. So some hospitals do not submit this to us. It's not a required. But if you're thinking that your hospital is, and you have a high percentage here, that would be a red flag, right? It's not mandated by us. But there are some organizations out there, trying to think if US World might be one of them, that do reporting, and we have a report built where you can report through us to them. And so you might want to submit that so that you can get your answers. So if you're not expecting that to be high, that would be a red flag. In missing inconsistent mother's date of birth. So there's just a lot of different measures in here that you can look at and go, wait, why is that so high? I don't want that to be so high. So we do try to help you with the accuracy of the information that you're putting in here. Like I said, I'm going to send this deck, so I'm going to speed through the rest of this so we can finish in case there are any questions that you guys have. But there's a lot of services that we provide, and all of this is in here. Customer support, like I said, specialized reports, enhancements. We do webinars that are only available to our hospital members, user group meetings. Let's see, I already went over how the hospitals utilize this, but here's an example of our US News and World report. A lot of hospitals do report to US News and World. They send us what they call an embargoed survey about a month before it's released to the world. We then go in and we update the MDC to match any changes that were made. But in the MDC, hospitals can go in and they can say, see my steps for using the report. They click here and it will show them anything that they need to do in order to update their data so that they can use the report. So it is really customized to their hospital and it will help them. So we're going to go through any questions and see if anybody has any questions. And I think that there are some. So I'm going to stop sharing. Oh, it's people sharing where they're from. I want to read through this too. Are there any questions for me? If not, I can go into the data center and show it live too, if you guys want. Yes, I'm going to send the slide, definitely.
Looks like Emily might have a question.
Hi.
Sure
This
thing.
was great. Thank you. I have actually several questions, and maybe you'll get to them when you do a demo. But
Okay.
So my first question was, you mentioned that the health equity data, and you said that there's, data by race, ethnicity, and I was just wondering if there's any other disparity variables that can be looked at, given some of the other variables that we know are important in maternal mortality and morbidity.
Absolutely. What are you looking for?
So we know in New Mexico, the maternal mortality review data indicates that payer type, so Medicaid versus private insurance,
Yes.
distance traveled, prenatal care, and so race, ethnicity, rurality, distance traveled, payer type, and sorry, I'm totally blanking. There's another one that we look at.
That's okay. That's
Yeah,
okay.
but
I don't think we have rurality, and I know that's a really big thing in New Mexico. When we first roll out the data center, we are going to have it the way it is, and we plan to do updates and customization to make it more New Mexico centric. We know that there are nuances for New Mexico that are different from California, different from Washington, different from Oregon. Oregon and Washington have morphed over time to be more custom to what they're working on. Each of the perinatal quality collaboratives have different focuses over time based on their demographics, their geographics, and what they see with their populations. And we're well aware of that. So that's an excellent question. Yes, we do have payer data. That is, I don't think different anywhere across the nation. The outcomes are different, right? The way that it's leaning is different, but that is definitely something that is focused on. And yes, we do have that. And that is very specific to the hospital submissions. We have, as a PQC in California, we do a form of scholarship based on that status. And we have one hospital system that refuses to submit theirs. And so they're just not eligible for that. And that's up to them. But I share that because every year we do have a couple nurses that will write in and they're like, why didn't we get that scholarship? And we have to tell them, like, go to your leadership. They won't submit their Medicare status. Like, it's hurtful to, like, you know, anyways. So yeah, if the hospital doesn't submit it, they can't look at it that way. Obviously, we can only, they can only review what they submit. So.
Awesome. And then my other question was about kind of you mentioned that you can, filter all of these data to look at some of these things by things like race and stuff. But I was wondering if within the tool, you can do any of that comparative analysis, where I know you showed there was sort of you called it something else, but it was like balancing measures, and to be able to look at those things, or to be able to look at any of these things, not just like filtered by, say, race, but like comparative analysis by race. I don't know if that makes sense, but not just being able to look at it, but being able to really do something comparative to look at it so that you can actually look at like these different variables at the same time.
So there's a couple things you can do. So we know that we all have different skill sets, right? I can guarantee you I deliver a baby, probably even blindfolded, way better than I can evaluate data. And I'm good at evaluating data. I wouldn't be doing this if I didn't. But delivering baby is definitely my forte over this. A biostats person cannot deliver baby as good as I can, but they do data way better than me. So that being said, the majority of the measures have a way to download the data to the patient level. And I want to preface this with, my team doesn't have the ability to do this. That is shut off. They cannot download anything. They can only see it on the screen. I want you guys to know that because of the whole HIPAA thing. But you guys can based on the access you have. So if somebody with the highest level of access could go in and download and then do analysis of that data at even a higher level than what's allowed in the MDC. Now, of course, you could do that straight from your PDD. So what's the difference? Well, because you could gather the data through a measure, so it's already kind of broken down to a specific level. So your focus is already brought down, and then you could do further analysis. Does that make sense? So yes, you can do a certain level, and then you could do even more outside of MDC if you still cannot. But let me share my screen and show you where we're at here. Let me know when you can see my screen.
We can see.
Okay, so I don't want to make it too small, but can you guys see it okay? So at the top, we're in, this is just a fake hospital, and I have the paired measure comparison. So I'm in NTSB. Do you guys want to yell out a different measure, or do you want me to stay here? I always pick this one because everybody's familiar with it.
That's fine.
Okay, and then right now I've picked my secondary measure as unexpected newborn complications. But when I click here, you can see all the other measures are here. I can pick any other measure. So I mean, it's unlimited. I can pick anything, but I'm picking unexpected newborn complications. They have a couple here that are suggested pairings, but I can pick any of them. I'm going to just do quarterly, and it updates real time. So, I mean, that's the other thing that's very, very cool. And then over here, I have my race and ethnicity section. So I can do a comparison, and I can do my breakdown by race and ethnicity, or I can do by payer, gestational age, delivery method, parity. I can select provider. There's a way to set up on your guys' side, practice group or prenatal care group. That doesn't come automatically set up as I'm sure it makes sense, right? Because we don't know who all those are. You guys would have to set those up. But over time, as you guys populate those, you could also evaluate that way. So if I did by payer, I can see Medicaid, private, self-pay, other, or unknown. Now, Ola Health has not submitted private and self-pay Medicaid, but you can see how if they were submitted, it would be in here.
Thank you.
Yeah. If I click on drivers, it evaluates it differently. And I'll tell you that we always have this. Please interpret cautiously. Many categories will have very small counts. So we always warn people of that. We want this data evaluated, but we want to be careful when people are looking at it because a small count, we don't want people to see 100% and think, oh, that's the key. You know, it needs to be evaluated, obviously, yes. So then it takes it into the drivers and it starts giving you your different races. And then you need to go in and pick and change the race. So right now it's focusing on Black and it's comparing it to the rest of the MDC for whatever, here it's doing it by nursery level. So now then you can go even deeper and pick what the comparative is here too. So right now it's doing it nursery level. So do you want to do a different compare here and here? So you can start breaking it down even further. Does that answer your question, Emily?
Yes, this
I mean,
is
you
great.
have some
Thank
fun
you.
in here. Let me tell you, you could spend just hours in here because then you go here and you're like, I want to do all the MDC and then here and okay, I want to look at, you know, Asian, but you could just start going and going. It really starts, there's a lot of granularity in here. I wanted also to show you guys, whoops, that's not what I wanted to do, sorry. So the data entry status, when I go here, this is where all the audits are. So you can select the measures that you want to audit. And there's all of these, there's a ton, there's a lot in here. So if I want to look at my NTSB abnormal fetal heart rate bundle consistency, it wasn't checked. I check it and hit save, it's now going to show up on the audit list. And so when I go back in here, I can go in and say, okay, I'm going to start auditing this. Well, it's showing me that for December, I have 4 records that based on the algorithm, it's saying these are the 4 that I should audit. So I'm going to go in now and this is based on a unit criteria. This is not like a national standard or CMQCC's way. This is your unit. And so what it's saying is that you should have a unit standard for how you want category 2 and 3 tracings handled. Now we have recommendations and there's a toolkit that talks about how they should be handled, but your unit should have a standard that you've educated your staff about, and then you should be auditing. Yes or no, were these cases handled that way? And so you can decide whether or not you want to do these chart reviews. And that's all of this QI that's built in here. And so that's one of the things that is going to be really exciting to have is this focused, standardized process around this. And then these all feed into measures, which is, I mean, if you go into any of them, oh, this one doesn't, oh, draw sample. So you can see the sampling here. There's 61 eligible cases, but I told it to draw the sample. So when I go to the bottom, it says view measure results. Every single one of these has a measure that goes with it that you're feeding the info into. Any other questions? And I will send the slides.
One thing I'll also send Melinda, and if you have an updated version, let me know. But there is a 3-pager that Melinda and her team came up with when speaking to leadership about the MDC. And so we'll also include that as well via email.
Yeah, no, that's the updated one, and it's also on our website. And I will send you guys also, we have this support section, which everybody with access has access to. But I will send you links to a couple things that are really important that talk about just a couple different items that are great for people to have.
Awesome. Emily, did you have another question?
I did. Sorry, if nobody else has any, I have one more,
That's
which is,
okay.
I'm just curious to know. So, I mean, this seems like it's very hospital based, but I'm just curious because some of, for example, the AIM bundles and things they extend into the ambulatory either pre or postnatally,
That's
and I was just,
such a
yeah.
such an excellent question. So the reason that this is hospital-based is because, well, first of all, that's how it started. And our agreements are hospital-based. So our legal agreements are based on hospital admission. That being said, we work with clinics, newer work over the last few years. We have LDA in here, and this is really clinic-based work. But the end goal is for it to help with preeclampsia, which is something that, of course, impacts the entire pregnancy and the rest of their life. But we end up looking at this information in the hospital based on their medication reconciliation. And so we did a lot of work. That was actually the project I was the clinical lead for. We did a lot of work in the clinic area with the clinics and how they could help the patients, and then we worked with the hospitals on how they could work on their medication administration reconciliation to help gather the information to look at compliance at the end of pregnancy to be able to gather the information. That being said, we currently are funded for, have not built yet, but in addition to the MDC, which will eventually be rolled out to New Mexico as well, for hospitals to be able to provide access to the clinic that they decide to provide access to, it will not provide the clinics any access to hospital data. Okay, I want that to be made clear because why would they have access to that? That's a HIPAA violation. Just because they deliver a patient doesn't mean they have access to their inpatient data, okay? But they will give them access to be able to build their own process measures. So they can then build that, yes, we screened every patient that came in to make sure that we knew their risk level for preeclampsia. Yes, we made sure that we verified every single time they came in that they were taking their low-dose aspirin. So now they can work on that. Just for example, there's also hemoglobin. We want to make sure they're checking hemoglobin and that they're looking for anemia and that all patients are coming in. I'm just giving you another example with a good hemoglobin level for delivery so that impacts that type of stuff. So yeah, that was an excellent question, and that will be coming next year sometime. Thank you, guys. I will send the slides.
Thank you all. We'll be in touch soon, Melinda. Thank you for your presentation.
Thank
It's
you.
always appreciated.
Thank you so much.
Thanks. This was great. Very helpful.